Good afternoon, and thank you everyone for joining today's media availability. A reminder to reporters on the line, enter the queue. You will be limited to one question and one follow-up. With that, I'd like to introduce Dr. Reka Gustafson, PHSA Vice President of Public Health and Wellness and Deputy Provincial Health Officer. Dr. Gustafson will begin with opening remarks.
Good afternoon, everybody, and I'm pleased to be here to raise some awareness and answer some questions about a topic that I'm very passionate about, which is public health surveillance. Public health surveillance actually has a formal definition. It's the systematic gathering, collection, analysis, and dissemination of data for the purposes of public health action. And its primary purpose is action. And the first purpose of collecting the information is actually to look after the person who happens to be infected with a communicable disease, and then to look after the people that they have been in contact with. Those data then are gathered by public health professionals, by clinicians in each of the health authorities and shared with BC-CDC. They're also gathered by the laboratories and shared by BC-CDC, where they are collated, again, for the primary purpose of recognizing patterns, understanding trends, and then shared with public health leadership, including our provincial health officer, all of our chief medical health officers, for the purposes of making decisions on controlling, in this particular case, the COVID-19 pandemic. It's an established process, and with every week and every day, we try to improve it. In addition to the use of data for decision-making, we make as much of the data as is possible, especially once validated and turned into meaning available publicly. And, of course, during the COVID-19 pandemic, there has been a particular interest in those data. And I look forward to any questions you may have about how that's done, how the decisions are made, how we support internal decision-making, how we support decision-making by health professionals, by public health professionals, by governments. But before I do that, I would like to hand it over to Dr. Bonnie Henry, our Provincial Health Officer, for some additional remarks.
Thanks, and thanks, Dr. Gustafson. I just want to reiterate from the very beginning of this pandemic and throughout the pandemic, the work of the BC-CDC on behalf of public health, on behalf of my office, to collect and analyze and understand all of the data that's come in, and it has been myriad and it has been changing over time. And then part of my role, of course, is to be able to speak to the public about those data, about what they mean, in a way that allows people to make the decisions that they need. But first and foremost, the surveillance data that we collect is for decision-making. As Dr. Gustafson said, it is really for information for action. And we have brought scientists together through the BC-CDC from across BC to help inform those decisions, to work through the data, to help us understand what it means and what's happening. And we have weekly technical meetings where that work is shared with people across the province to help us understand what we need to do. And then it's used by the health authorities, by myself, by our provincial response to make the decisions that we need. And you will be familiar with the evolution of what we have presented publicly over time through our weekly surveillance bulletins from the BC-CDC, the Friday updates to the dashboards, to the maps. And as we get more information and more detailed information, we present that as well. And you will know that every month, for over a year now, we have done what we've called our modeling presentations, and that is very much supported by the work that's done at the BC-CDC to pull these data together. And all of these data are made public in a way that it can help inform what people understand about this pandemic and how we're managing it and progressing through it together. So I will leave it at that, and we are happy, as we said, to take questions.
A reminder to reporters on the line, please press *1 to enter the queue. You will be limited to one question and one follow-up. For the first question, we go to Justine Hunter, Globe and Mail.
Hi, thank you. The data that was released perhaps grudgingly from the BC-CDC this week shows a case positivity rate of more than 20% in these communities in Northwest Surrey, but that's as high as the scale goes. So I'm wondering if you can tell us what the actual positivity rate is.
Well, I probably don't have that right at my fingertips, but we tend to do. You're absolutely right. We tend to have a scale, and I can look into what the range of positivity rates were, and see whether we can provide that for you. I think one of the things to keep in mind is that positivity rates at very small geographic levels become highly unstable. So especially when you use a fairly short period of time to report them. So that's one of the reasons that we go above 20%, because we might actually be, and not necessarily give an absolute number, because we might be reporting on a very small number of tests at any one time. So it won't necessarily be meaningful, but we're happy to follow up on that.
Yeah. So just to follow up on what Reka's saying, see, that is one of the reasons why we look at these data over time. It really is not, is it 10.1 today or 20.2, or is it higher or lower? It's about what is the trend that's happening, how many tests are done, how many people are, is it because we've targeted certain areas for testing that we've had an increase? Is it because we've done testing in a known outbreak in a food plant in that area that has meant that we've uncovered a number of positive people who may be asymptomatic but contacts? So there's a whole lot of context that goes into it. That's why we report these as heat maps, because they give us an understanding of trends over time. And those are what we've been using to help identify where we're seeing. So you need to understand what the backstory is before you understand what the numbers are. And that's the work that we do in our data groups together to say, okay, why is it that we're seeing this community light up right now and that community light up the next week? So those are the things that help us make decisions. And we've presented some of these heat maps, but we've also presented the dot plots that we've been using more recently to help us understand which communities are going up and down over time and seeing trends over time. So it's not a single number that gives any meaningful information.
Justine, do you have a follow-up?
I do, thanks. Yeah, it does seem that given what we've seen in terms of action from Fraser Health this week, and the Premier coming into Surrey and speaking to members of the community to try and enlist people on vaccination rates, that there is something going on in this region. So, and I guess I'm wondering, is there any chance we can even move to easing restrictions so long as these communities are experiencing a high rate of COVID as we're seeing here?
Yeah, but, this is not new. We've been reporting on local health area rates of disease for over a year now, and we know that there's been an issue in Surrey. It has been for a long time. So this is at a more granular level with some newer data that we've been able to link more recently. But it has been a focus, and we focused on many communities as we've progressed, particularly over the last few months. We recognized Prince Rupert and Whistler and Golden and a few other places as we have been able to more, as we've had vaccine and being able to understand the impact of vaccine and trying to target it. So it is not a surprise, I don't think, to anybody that Surrey has been a challenging area of concern for most of this pandemic.
For the next question, we go to...
I'm sorry, you had also talked about lifting of restrictions, and those are things that we're talking about. How do we do this in a way that's not going to allow flare-ups? We have seen that, the Lower Mainland has been the area where we have the most population, where we have the most risky businesses, etc., and where we do see flare-ups ongoing. Although no area of the province has been spared, except maybe over here on Vancouver Island. So yes, restrictions, we are looking at how do we do this in a way that is going to allow us. I think around the world we're accepting that COVID zero is not a viable option once you have a lot of transmission in your community, and we've been in that place for a long time. So it's about how do we make sure we're protecting people who are most at risk, and that's where vaccination, thankfully, comes in. And then how do we manage it as we would any other respiratory illness from a public health perspective? Detecting outbreaks early, and that goes to testing again, making sure that we can do outbreak management, including catching up on immunization, making sure that people are protected as much as possible so that we aren't getting that the impacts on our healthcare system that make it so challenging to manage this disease. So with those things in place, we can start doing things again, like having gatherings indoors, like having larger groups of people coming together that are protected, with understanding that it's not zero risk, but that the risk will go down dramatically and that we can detect and manage things quickly.
May I add just one point to Justine's question?
Go ahead.
Thank you. So just your question about lifting restrictions given the rate of disease. I think what's really changed, over the last several months, is that restrictions were our primary mode of controlling COVID-19 because we didn't have the definitive preventive intervention, which is vaccination. So as we move along the vaccination campaign, as we continue to protect communities through immunization, the daily rates or the control measures will shift away from restrictions, which are temporizing measures when you don't have a definitive prevention measure in place, to immunization as our primary goal and our primary intervention. Thanks.
Thank you. For the next question, we'll go to Richard Zussman, Global News.
You assume that these CDC reports are produced on a weekly basis. Will you commit to releasing them publicly now that we see that they're available each week?
Yeah, so just I'll let Reka answer that. But just to say that that we do release almost all of that information that was in some of the reports that were posted. It comes out in various different forms. But those were working copies where we had, for example, several different ways of looking at variants of concern. And we have a discussion about which is the one that's most meaningful. And that's the one that's released, and it'll be released again today. You've seen them. Those are where we have the graphs that have the green line telling you the percent positive, and we have for all of BC and then for each of the health authorities. So it's a matter of those are working copies, if you will, and the vast majority of what's in those is released in various forms on a weekly basis.
Richard, sorry, Dr. Gustafson, go ahead.
Just to reiterate that, so the slide deck that you have is in fact our working copy that we share with. It's a work in progress. We share with our public health colleagues for validation, to go from data to information to meaning, and then eventually to understanding. And again, the vast majority is released. I think it was helpful to hear that people found the format and the way in which it was presented helpful, and we're working with our public health colleagues to see which, whether that's a useful way of releasing information. It's essentially, just for your information, it's essentially for public health physicians and clinicians, it's essentially our clinical chart. It's what allows us to think through what's happening. The format may benefit from some validation, even from some feedback from others saying, well, this could be misleading, this could be misinterpreted. But again, we really do endeavor to share as much of it publicly as we can, with often just capacity and resources to get there, to human beings to get it there, being one of our rate limiting steps, because it's actually a significant amount of work. But I just want you to be aware that none of that information is in any way concerning for us when it's in the public domain. Thanks.
Richard, do you have a follow-up?
There'll be a lot of frustration, though, by that answer, that why not, if the work is already being done, just take this exact work. If you trust the public to consume it, just provide it directly to the public. And are you worried that, the idea that this information is not distributed in this form directly to the public could erode public trust in what's being done from public health?
Well, I think we need to recognize that everybody has, there's a process that it goes through before it's meaningful. And as Dr. Gustafson was trying to explain, we have as well processes for reporting of health data to ensure that they can't be linked. And so these data are reported through the surveillance report, where there's context added, and you have to hear the conversations about each of those before you know what they actually mean. So they are put into a context and released publicly.
For the next question,
and also, again, just to give you a sense, it's essentially the draft. It's the draft that requires and benefits from validation from our partners, and in particular, one of the most important principles from my perspective is the people who provided the data need to have a look at it and understand it and make sure that it actually reflects the meaning that they're experiencing on the ground. So again, we really are happy to release it. On the other hand, data quality and ensuring sort of the validity of what we're putting out there does require a degree of validation by people who understand the data. Data are alive; they're moving and living things that you have to live with. And our purpose is to not limit information; is to provide it the highest quality we can.
For the next question, we go to Katie DeRosa, Vancouver Sun.
Hi, Dr. Henry. In comparison, you're calling this yourself and Dr. Gustafson are calling this a draft, but other provinces will release this almost on a rolling daily basis, where they have neighborhood-specific information that updates every day that shows, active cases, cases of the variant, and again specific to certain neighborhoods. So. Again, it takes this long to find out that parts of Surrey had such a disparity between COVID hotspots versus vaccinations. Wouldn't that be an important piece of information that could help drive, vaccinations among, local community groups? So why not release this to the same extent that other provinces are releasing right now?
And we are releasing the things that more than what other provinces are releasing, and I think you're talking about Toronto Public Health and some of the neighborhood data that Toronto Public Health has. And the reality is that the information by CHSA around vaccination levels has only become available since our provincial registration system and booking system has been put in place, so April 6th, and being able to link that data to our CHSA and to the case data. So that's all very new information that we've released as soon as we've had it available. And Reka, I don't know if you want to add to that.
No, I just completely agree. And again, one of the things to keep in mind is that we don't have the exact same data processes, but I do invite all of you to go deeper into the BC CDC website, because there's a great deal of information there, a lot of local information, including positivity rates in cases per neighborhood or per a local health area. And again, when there is an interest in a certain type of granularity, we go through a process to create those data, to collate those data, and to put it out publicly. And it won't be on the exact time scale of another jurisdiction, but our goal is always to get there. And I do invite you to go past the dashboard and go to our situation reports, to our COVID-19 epidemiology app, and our maps and our vaccination data. And what I can commit to is that every single day we're looking at making it better, making it more accessible, and in particular making it more user-friendly.
Yeah, and on that note, when there is some, this, as I said, is relatively new data that we've started to be able to collect, and Reka has been working very hard in the BC CDC to put it in an interactive format, and so I'm hoping by early next week we'll be able to have that so people can look at age groups and demographics. And I know Katie, you had reported on things like women are being immunized more than men, but there's a context to that, right? Because we know that there are more women that are healthcare workers that were eligible for vaccine early and things like that. So that's all the important context that it helps to have around some of these data.
Katie, do you have a follow-up? Yes, please. So that being said, what specifically is going to change? Like, Dr. Gustafson said, we're looking at making things better. And with the acknowledgement that the public does want this information and that it is valuable, what changes will be made to make this information more accessible at the sort of neighborhood level data, even data around certain professions so that we can understand which workplaces are being impacted? Like, what is going to change going forward?
So one of the things we're working on right now is actually that combination of neighborhood-level case and immunization rate. That's our goal in the coming, in the coming weeks. And I think the other thing to keep in mind, and just a little bit of a comparison to Toronto, is one of the things we really aim for is provincial-level data. So a single health unit may be able to report a level of data that's different than what we can do at a provincial level. But if you look at our information, most of all of it actually aims to provide the same level of granularity at the provincial level. So I just wanted to clarify that for you. But yes, our next goal is neighborhood level immunization and case rate in the same time period, so you can compare.
So you can compare, and also looking by demographics, so age and sex. So that will be coming very soon. I'd love to be able to report by workplace, but we don't actually collect that information. And this is one of the challenges that we have across the country, that we don't have a simple way to collect some of that disaggregated data, to collect data by occupation in a meaningful way. So we know some of the businesses that have had outbreaks because we collect that, but it's not in a way that can be presented in a standardized format. It's in a lot of it is on paper still. So these are the trials that we're trying to get meaningful data, despite the fact that we don't actually have systems to support the same sort of, what am I trying to say, the consistent collection of the same data over time. It's a very challenging thing. It's something that was identified, at least in my world, after the SARS outbreak in 2003, where I was putting different color stickies on a wall to try and connect people. In some ways, we've made great progress in pulling together data systems, but in other ways, we have huge, huge gaps still. We don't have a single reporting system to the Public Health Agency of Canada, so that means across the country, every province has a different way of collecting information and reporting on it, and that's something that I hope we will address after this crisis.
Next question, Penny Daplo, CTV.
Oh, hi there. You said that the surveillance data you collected for decision-making, but other public health officials across the country have made this level of detailed information around infection, for example, available to the public to make their decisions. And it's not just Toronto, it's also in Edmonton. They provide a lot of neighborhood-level information, and they don't require leaks to the media to find out what's happening in their neighborhood. So I just want to know, 14 months into this pandemic, why is it that you've decided now that we're weeks away from getting this kind of detailed information?
We have been providing information as cases increase so that they can't be identifiable by local health area, and that's the equivalent that we have in this province of neighborhood data. And more recently, as I just said, we have been able to link with what we call community health service areas, which are smaller units. In some areas, they're smaller units. In some areas, they're larger, depending on the population. So it's a standard unit that we use in BC that is comparable to different units that are used in other health authorities. And Reka, I don't know if you want to address that as well.
The only thing I would say is that word leak. The deck that was shared with you is actually shared with quite a broad range of people. We always assume that it might become public, so I think it just wanted to make sure that we don't mischaracterize it. That there was sort of, again, a particular concern about it being shared, it wasn't yet of the validation or the standard that we were necessarily ready to put it out proactively. And as we mentioned before, a limited number of people are working on a number of data products. And depending on what is of interest at that time, we are focusing on one over the other. So over the last little while, we have been, as Dr. Henry mentioned, we have been providing case data, percent positivity, comparative data, hospitalization data, death data at the local health area level. And we have focused over the last little while on making sure that those data are available to you in a more user-friendly manner, as well as really making the linkages and the data processes available to provide immunization data by those local health areas or those units. So that's what we've been focused on until now. So completely appreciate that there's interest on CHSA level data. So that's what's coming next. And I would say that again, it's a relatively small group of people who are focusing, whose primary focus is actually at the gathering stage is to look after the people who have COVID-19, look after their contacts. In the process of that care that they provide, they also gather data, which they provide provincially, and we are working as hard as we possibly can to make sure that those data are again gathered, synthesized, and provided to you. And really appreciate the interest in it, and the discussion really tells us where you are, where the public is, and where the interest lies today.
Penny, do you have a follow-up?
I do, yeah, and I just, I want to acknowledge that I can hear that you think that you are being transparent with the public and that you're providing information, but at the same time, I do think a lot of the public, a lot of experts, a lot of community leaders are feeling that they're being kept in the dark with a lot of this information. For example, the South Asian COVID Task Force, they tell me they're calling for a reset. They want you to provide the community with greater transparency and detail going forward. So you're talking about providing more information a few weeks from now. I get that, but will you commit here and now to the level of detail that we've seen in this report when you do make more information available?
Yes. I mean, that's a fairly simple answer. Again, the vast majority of the data that's in there is already available. And the one thing that I would like to just address specifically is you're probably referring to ethnicity data. And those data we do not collect for each case of COVID-19. So if that's the data, if that's the request, that is not data that we have available to us in BC.
Next question, we go to Joel Ballard, CBC.
Hello, thank you for taking our questions. The first one is, we often hear about stigmatization and privacy as reasons for not sharing more specific local data, but we've had many individuals and groups full of diverse populations, like Penny just mentioned, the COVID South Asian Task Force, call for more data, saying better information outweighs the risk of stigmatization at this point. Can you point to any actual groups in BC that believe otherwise, that are not calling for that data to be shared? Because right now we're just hearing for more data, and that it trumps the need for privacy or the possible stigmatization.
Yeah, so there's a couple of things around that. One is, as Dr. Gustafson says, we don't collect certain data that people want, and we would love it too. It certainly is important. But we have seen repeatedly that there are people who are stigmatized who have COVID. And, we only need to look at the anti-Asian racism that we're seeing, the anti-Indigenous racism that we're seeing. So it is about finding that balance and doing the best with the data that we have to try and ensure that we are not putting out data. And there's also legal constructs that we have to follow to ensure that data cannot be re-identified. So we are very cognizant of that. That's why we've changed the unit of geography, for example, over time. Very early on, when there was only 1 or 2 cases in an area, they could be identified. So we have to follow appropriate privacy protocols to protect those communities. I also think there's another side to this, which has also shown itself very often, that people think that they have no risk if there's not a high rate of transmission or cases identified in their community. And again, that's not the case. We need to all be wary that people bring risk with them. This is a virus that's transmitted by people, and people moving can bring a risk to an area where they may not feel that sense that they're at risk at all. And we look at Nova Scotia as a classic example of that. By the time it's recognized, unfortunately, there can be quite a lot of transmission. So it is trying to find that balance of providing the right information that people can use to make the decisions at their level, and the information that we have, the data that we actually collect on a day-to-day basis.
Joel, do you have a follow-up?
Yes, please. This, again, is for Dr. Henry. You've mentioned that most of this data has been or is available to the public, but at least here at CBC for 15 days, we've been asking the BC CDC, the Ministry of Health, if case counts for all the community health service areas were typically gathered each week. We still haven't received a response on that, so I'm just wondering, do you think that's appropriate not to share that, and are you able to commit to providing that information now going forward, now that we know that it is being collected?
Well, it's not actually being collected each week at the CHSA level. That is data that's been converted, and as I said, we just started being able to do that very, very recently in the last couple of weeks. And don't underestimate, and I'll pass it to Reka for this, how much time it takes to actually link data by CHSA. So it has taken many weeks to be able to do that in a way that doesn't... I don't know how many people on the line have worked with large databases and linked databases. So it has been a struggle, a challenge to try and get those data and make sure they're valid. But I know we're committed to providing cumulative cases by CHSA as soon as they're able to validate those data. And I know Reka, as part of her team, has been working very hard on that. So the short answer is yes, we will commit to getting you that.
And next question is Martin McMahon, News 1130.
Hi, doctors. Thanks for taking my question. I mean, I'm still just trying to get this in terms of what has been your concern about releasing more detailed information, some real, tangible, potential negative consequences if people had this information before.
I can...
Go ahead.
So, and that was actually the previous question as well. So as the pandemic was evolving, we actually did have tangible, specific concerns about receiving very granular data, especially in communities that had very few cases. And in those communities, there were specific concern raised by the leaders of those communities that individuals and families would be identified and stigmatized in that community. And so that is the specific concern. We're not there now. The rate of COVID-19 infections is much higher right now, and a number of cases in the vast majority of British Columbia's communities, not all, does not pose a risk of a person who does not want to share their personal clinical information with the entire community being identified as such. The issue may rise again when immunization will reduce the number of cases again. And so that's a consideration with any communicable disease. Keeping in mind that a communicable disease is not just your health information, it implies information about somebody who gave it to you and somebody you could give it to. So there are personal concerns associated with that, but again, we are not in that phase of the COVID-19 pandemic right now, and I would say that those concerns have diminished quite significantly over the last several months.
Martin, do you have a follow-up?
Yes. From speaking with some of our listeners, I get the sense, I mean, they're saying that withholding this data, they feel they've been condescended to. I mean, what do you say to people who feel like they've been left in the dark here?
Yeah, I think, we try to provide as much light as we possibly can within the bounds of protecting people's privacy, as Dr. Gustafson just so eloquently described. And we know there have been cases, and you know of them as well, where people have been discriminated against because of people assuming things about them based on data. So it is finding that balance. We have been very open from the very beginning, where we presented as much as we could by areas, and the information that we provide with it. People always want more, unless you're the one that's potentially at risk. And so we do have to find that balance. That's part of our job in public health, to maintain that trust for people who are sick with COVID, and to be able to provide, so that they will provide us the information we need to try and identify who's at risk and manage cases and clusters. So it is very much a balancing act that is important for us in public health to maintain trust.
Next question, Shrishti Gangdev, Burnaby Beacon.
Hi, thank you for taking my question. I understand what you're saying about, acts of stigmatization and discrimination. I talked to an advocate today who called that approach paternalistic, harmful to their communities because they don't have the information they need to protect their communities. What's your response to her? She says it ignores and covers up the discrimination in the public health system itself by not addressing the root causes of those inequities that make them more likely to be impacted by COVID in the first place.
Yeah, I think. Go ahead.
So I think those are really important comments. And one of the things that this pandemic will have resulted in is more open dialogue about data and about how we use our data and what is the right level of information. So I think, again, referring back to the previous question about this idea that people are being condescended to, a couple of things just to reiterate is that the data that we can share are data that we have. And the primary purpose of collecting the data in the first place is to look after you and to look after your contacts. So think a little bit about what question your doctor would ask you, what question your public health nurse would ask you, and that's the information we're working with. So more data that people want may actually not simply not exist because it wasn't collected in the course of looking after somebody. So that's one thing. The other is the level of granularity and timeliness. I completely hear you and acknowledge that there are people who would like it more granular and more timely, and there are others who want it less granular or less timely. And we absolutely do make judgment calls about that, and I welcome dialogue about that in the public space, because with increased interconnectedness of information systems and more data being available, the opportunity to have more data made available is there, and I think it's going to be an important public dialogue.
Absolutely, and I think that is something we have learned about this. But the reality is we do not have disaggregated data by race and by certain communities, and it's just not something that we've been able to collect, and that is something that we need to address as a country and as a province going forward. We have been able to link with First Nations data and we, because of the First Nations client file, and we do have a whole process about ownership and management of data, First Nations data, and that belongs to the First Nations communities and First Nations Health Authority. And we have been working with them to use that data as best they can to protect communities, and that's these are all very challenging questions that we need to continue to have dialogue on. But it is really hard that we don't have the information that a lot of people would want.
Kirsty, do you have a follow-up?
I do, thank you. How do you think people living in Wally and Newton or other areas with positivity rates over 20%, where there are majority, racialized communities in high-density neighborhoods who work in essential workplaces, who are, again, more likely to be impacted by this pandemic because of systemic inequities in the public health system? How do they feel about your approach to data or collecting data or even to responding to their situation when the affluent community of White Rocks, like 10, 15 minutes away from them, has a positivity rate of 1%.
Yeah, these are exactly the questions that we, or the conversations we have with communities, and that's what public health is doing on an ongoing basis. And you have heard me say many, many times why we know that there are rates that are much higher in Surrey and in different communities within Surrey for those very reasons. They're essential workers. They're people who are working in our healthcare system, or working in our food processing plants, who are living in multi-generational families. Those are the information that we share with people on a one-on-one basis, on a family basis. And, this is not new. This is what we have been talking about through this entire pandemic. And these systemic inequities are not a public health issue. They are what has been revealed by this virus and this pandemic, that we don't value low-wage earners, that they don't have the ability to stay home. And so part of the response that we have been doing through this whole pandemic has been trying to find ways to support workers, and that's one of the reasons we prioritized, food processing workers for immunization, because we recognized that these were high-risk environments where people had no choice but were being exposed to this virus, and that's why healthcare workers were prioritized, why we prioritized long-term care homes where we knew there was a differential impact. So these are all really important societal questions that have been revealed by this pandemic, for sure.
And the only thing I would add to that, which I think is important, is that you're speaking to the Provincial Health Officer and you're speaking to the BC Centre for Disease Control. We have a provincial scope. However, the disease trends, positivity rates, immunization rates, are also monitored closely by local public health, and they deploy their resources based on where they're seeing clusters, where they're seeing surges, where they're seeing high positivity rates. And those resources might be their testing resources. They might be their contact tracing resources or immunization resources. So I think it is important to remember that public health is managed very, very closely at the local level, and local medical health officers are working with their communities and engaging with their communities all the time. So whether it's on a provincial map or not today does not mean that community is not receiving the public health management and the care that is needed. And local public health has been working incredibly hard during this pandemic to meet the needs of their local community.
Next question, Rob Monroe, Info News.
Hi, doctors. From what I understand, you have the information on neighborhoods. I'm in Kelowna. The local health area maps have the central Okanagan, the most populous area, as a one local health area, and it doesn't break that down. Yet we have small communities of maybe 4,000 or 5,000 people that are broken down as local health areas. We just had a neighborhood in Kelowna identified as a high transmission neighborhood. So you've had that breakdown, particularly for the central Okanagan, for some time. So with the release of this information, why have we not had that information sooner? And are you saying it's going to be weeks yet before we can just get case numbers on these smaller areas or even cities within the central Okanagan?
No, I think this information is information that we've put together from multiple databases in the last few weeks, and we are working very hard to have it available publicly, and it takes time to develop those maps. And yes, I think the first one of them is a combination of CHSA and CHSA maps that were released around case rates last Friday, and there's going to be more detailed on the immunization rates released, I believe, next week.
Rob, do you have a follow-up?
Well, just on that, you're saying it's still going to be weeks before we get this broken down by neighborhoods, even though that data is available now?
Yes. By CHSA, and that's what we're talking about. That's the data we have. And then I didn't say weeks, I said by next week.
Yes.
You know, one of them's been released already, but then the detailed immunization piece is going to be, I am hopeful, will be ready by next week. Reka?
Yes, that's what we're working toward. Again, I just want to reiterate, at a provincial level, your local medical health officers and your local public health systems have the kind of local knowledge that they need to make sure that they are managing outbreaks and clusters and exposures in schools and all the day-to-day management of COVID-19 on the ground at the granular level. And I think I just can't overemphasize that, because I'm concerned that there might be a linkage drawn between management of COVID-19 and whether the data appear on a map on the BC CDC website. Public reporting is an important thing to do, and we are absolutely committed, as Dr. Henry said, to provide you that information. But the information exists in the hands of people who are serving the community day to day, and I think that's where the data are gathered, that's where they are immediately applied, and that process of collecting it provincially and analyzing it and synthesizing it does take some resources and does take some time. Absolutely hear that you want it as soon as possible, and that is absolutely taken on board. And but I just think it is important that we're clear that it being published provincially is not the rate limiting step for it being used for action, which is the primary purpose.
And we have time for one last question. We go to Mary Griffin, Check News. Mary, are you on mute? Okay, failing that, we will go to Rob Buckham, CTV Vancouver Island.
Oh, hi. Thank you for taking my question. I'm just wondering about, in looking at that report, and I'm speaking with Dr. Stanwyck on the island, our case counts are down to 19 a day on average. Our positivity rates and transmission rates are very low, and he'd indicated he'd looked into or was exploring the idea or hopeful about having a regional approach where restrictions would be eased here, and he'd run that by you, Dr. Henry. I'm wondering, is there any chance we could see that in the future, a regional approach, especially for the island, where, as you acknowledged earlier today, things are looking basically better than they are in other health regions?
They have been for some time, and I think there's a combination of reasons for that. But we're not immune to people traveling in and spreading, as we have seen. You know, when rates go up in the Lower Mainland, it's almost inevitable that rates go up in other places too. And the reality is we're not out of the woods anywhere until everywhere is out of the woods. And, you know, our neighbors in Alberta are having struggles right now, same in Washington State. And so we will look at it as we continue through this. We've tried a regional approach before, and it's not been successful. And we see that this virus spreads pretty widely and pretty quickly, and there's a lot of connectivity around the province, despite us trying to reduce travel.
Rob, do you have a follow-up?
Never say never.
Rob, any follow-up for you?
So you're saying there's a chance. I guess my next question is, in light of what you just said, you know, that a regional approach was not on the table, most likely. What do you say to restaurant workers here on the island who are hearing about restaurant workers on the mainland getting their shots today being prioritized? And it's my understanding that there are no plans to include restaurant workers in island health in that frontline group to be prioritized. Doesn't that seem sort of contradictory or like a double standard of some sort?
No, and we are moving. So the worker program, as you know, the frontline worker program was a little bit off the rails when we had a lack of vaccine, and the AstraZeneca program was suspended for frontline workers by age. But we're back on track now, and as we have more vaccine, we did start with the highest risk communities, as you've seen. So it was starting in the Lower Mainland with first responders and school staff and childcare staff. And I know that spread around the province now, so we're able to do all of those groups in everywhere, including here on the island, and they'll be caught up within the next week to 10 days. And we've also, as more vaccine has become available, really this week has been a turning point for us in the amount of vaccine that we're receiving, and because we've set up the clinics the way they are, they can expand rapidly. So we've had about 15% of the vaccine program that's been, of the Pfizer-Moderna program that's been used for the worker program, and now that more vaccine is coming in, that 15% is expanded. So we will be seeing other groups that have been on our list, including grocery store workers, food service workers, starting in Vancouver Coastal and Fraser, and expanding around the province as vaccine supplies ramp up in the next few weeks. So you will be seeing it here too.
And that's all we have time for today. Thank you, everybody, for joining today's call.
Thank you.
Thank you.